The wrist or carpus is easily my favorite joint. It presents a combination of motion and stability that is unmatched in the human body. The wrist provides motion in three planes and stability with both distraction and compression. Over the next several minutes, we will explore this joint. References include multiple articles and books. Special acknowledgement goes to Julio Telesnik's The Wrist. The human wrist normally consists of 8 carpal bones and their connections to the hand metacarpals, the radius, and the ulna. This number varies by species, with carnivores having 7 and ruminants only 6. These are conventionally divided into 2 rows. The distal row contains the trapezium, trapezoid, capitate, and hamate. The proximal row contains the scaphoid, lunate, triquetrum, and pisiform. I realize I'm using a mix of Latin and Greek derivatives, but these names are those most common in use in the hand literature. In approximately 0.1% of individuals, there will be less than 8 carpals with coalition of 2 or more bones. This is most commonly a lunate triquetral coalition. This is seen in close to 10% of certain West African groups and their descendants. This is followed at a distant second by capitate hamate coalition. Rarely, capitate trapezoid, scaphoid trapezium, scaphoid lunate, and pisiform hamate coalitions are encountered. These coalitions are generally incidental findings and are asymptomatic. Coalitions can be syndromic, Ellis von Creveld syndrome, Holt-Oram syndrome, fetal alcohol syndrome, odo-pallo-digital spectrum disorders, Turner syndrome, symphangilism, and Nevergelt syndrome. They can be isolated, transmitted via a Mendelian inheritance pattern. They can also be acquired, usually through inflammatory arthropathy, such as rheumatoid arthritis, juvenile arthritis, or psoriatic arthritis. The carpal bones are held in place by the wrist capsule. There are multiple ligaments embedded within the wrist capsule performing specific functions. There are also ligaments within the joint that directly connect specific carpal bones. Ligaments are classified extrinsic if they connect a carpal bone to the radius, ulna, or metacarpals. Intrinsic ligaments connect carpal bones directly. Several of these ligaments are worth pointing out because of their importance in wrist stability and our discussion of biomechanics. We will start with the volar extrinsic ligaments. The most ulnar radial ligament attaches from the radius to the lunate and variably to the scaphoid. It is known variably as the short radial lunate or radial scapholunate ligament. Going radial, the next ligaments are the long radial lunate, the radial scaphocapitate, and the radial collateral. Volar ulnar carpal connections to the carpus is through the ulnar lunate and the ulnar triquetral ligaments. Dorsally, the main extrinsic ligament is the dorsal radial carpal ligament connecting the radius to the triquetrum. The dorsal intercarpal ligament connects the triquetrum to the scaphoid, trapezoid, and variably the trapezium. The importance of these 2 ligaments will become obvious. 2 intrinsic ligaments deserve our attention. This is the scapholunate and the lunotriquetral ligaments. They play a central role in carpal kinematics. There is a multitude of other volar and dorsal ligaments, both intrinsic and extrinsic, but these will serve our needs for now. Wrist flexion, extension, radial and ulnar deviation occur centered through the head of the capitate. Wrist flexion averages in the 65 to 70 degree range with significant variations. Approximately 60% of this motion occurs through the intercarpal joint, the rest through the radial carpal joint. The proximal row also moves slightly dorsal on the scaphoid facet. Wrist extension averages 50 to 55 degrees, again with significant variation. However, with extension, 2/3 of the motion occurs through the radial carpal joint. Radial deviation averages only 15 degrees, with 90% through the intercarpal joint. Ulnar deviation averages 35 degrees, split evenly between the 2 joints. Historically, there have been numerous models used to try to explain carpal motion. 2 have lasted the test of time. The carpus is classically divided into a distal and proximal row. This anatomically coincides with the actual joint structure with the radial carpal and the intercarpal joint. The main actors of the proximal row, the scaphoid, lunate, and triquetrum, have no muscle attachments. These three bones are intercalated between the distal row and the radius/ulna. Most of the compressive forces across the wrist are transmitted through the capitate, across the lunate, and into the distal radius. The proximal row, and in particular the lunate, represented an intercalated segment. Compressive forces from the flexors and extensors pass from the capitate to the radius through the lunate. The ligamentous laxity necessary for motion in the wrist subjects the lunate to the risk of a zigzag collapse pattern. If the lunate rolls distal facet dorsal, the hand moves dorsal, and a dorsal intercalated segmental instability, a DISI, exists. If the lunate rolls in the other direction, the hand moves volar, and a volar intercalated segmental instability, a VISI, exists. The volar inclination of the distal radial facet and the tear-shaped appearance of the lunate predispose to a DISI, but also helps prevent a VISI. The bone and ligamentous structures of the wrist prevent this phenomenon under normal circumstances. In one columnar model, the capitate and lunate are assigned to a central column. The scaphoid, trapezium, and trapezoid are assigned to the lateral column. Their triquetrum, hamate, and pisiform are assigned to the medial column. In a more simplified model, the entire distal row is assigned to the central column. In general, the distal row moves as a unit, and this probably makes more sense. The kinematics are the same. The central goal of these models is to explain how the lunate escapes an intercalated segmental instability with such large compressive forces and a large range of motion. The scaphoid has a unique position in the lateral column configuration. It serves as an obvious link between the proximal and distal rows. It is tied to the lunate with the intrinsic scapholunate ligament, as well as the volar radial scapholunate ligament. It is attached to the distal row through ligaments to the capitate, trapezium, and trapezoid. Dorsally, this attachment is augmented through the dorsal intercarpal ligament. Flexion of the distal row through the head of capitate forces scaphoid flexion. This scaphoid flexion, in turn, produces volar rotation of the lunate through the scapholunate ligament. Furthermore, flexion of the scaphoid over the radial scaphocapitate sling lifts the proximal scaphoid and thus the lunate dorsal on the radial facet. This dorsal movement tightens the volar extrinsic ligaments and flexes the lunate. Extension of the distal row reverses these effects. This all serves to maintain a collinear relationship between the capitate, lunate, and distal radius. Radial deviation foreshortens the distance between the trapezoid/trapezium and the lunate, forcing the scaphoid to flex, producing similar effects as wrist flexion. Kinematics in the medial column, the triquetrum, is somewhat more complicated. Although the lunate attachment through the lunotriquetral intrinsic ligament mirrors that of the scaphoid, the distal interactions are less obvious. The hamate articulation for the lunate is a helicoidal configuration. Moving distally, the articulation rotates in a corkscrew manner, becoming more volar and more radial oriented. With neutral wrist rotation, the triquetrum sits proximal on the hamate articulation. With ulnar deviation, the triquetrum moves distal and volar on the hamate articulation. This produces rotation of the proximal triquetrum in a volar direction. The triquetrum itself is also translated more volar on the hamate. These motions mimic the flexion/radial deviation effects of the scaphoid on the lunate, but in an opposite manner. Dorsal rotation of the lunate with volar displacement on the radial facet occurs. The opposing forces of the medial and lateral columns on the lunate stabilize the lunate with radial/ulnar deviation, flexion/extension, and compressive forces. Dorsally, two columns are linked through the dorsal intercarpal ligament. The lateral column forces appear somewhat more secure than the medial column. This aligns with the natural tendency for a DIS collapse, predisposed by the distal radius volar tilt and the tear-shaped lunate. With the exceptions Instability of the wrist usually results in either a DISI or a VISI pattern. Lateral column injuries generally lead to DISI patterns, and medial column injuries generally lead to VISI patterns. VISI patterns are more likely in rheumatoid arthritis. With lateral column injuries such as unstable scaphoid fractures and scapholunate tears, the volar rotation and dorsal displacement force on the lunate is lost. In this case, we have disruption of the volar radio-carpal ligaments and the scapholunate ligament. The volar tilt of the distal radius, tear-shaped anatomy of the lunate, and unopposed dorsal rotation of the medial column lead to a DISI collapse pattern. Depending on the degree of injury, this may be a dynamic or static instability. Dynamic instability is more likely with isolated injuries to the volar radial ligaments. With disruption of the radioscaphal capitate ligament, the capitate is no longer tethered to the scaphoid. Loss of this ligamentous sling allows the proximal scaphoid to sublux volar with similar subluxation and rotation of the lunate. Varying degrees of lateral column injury modulates the level of laxity. Dynamic instability can be demonstrated with Watson's maneuver. In such cases, dorsal translation of the capitate through pressure on the trapezium produces a DISI. Isolated medial column injuries tend to produce VISI instabilities for similar reasons. However, isolated medial column fractures and ligament injuries are more rare. VISI patterns are more common with generalized joint laxity. This can be congenital, traumatic after incomplete healing in the medial column, or acquired such as rheumatoid arthritis. Dynamic instabilities are also more common in VISI patterns. The catch-up clump test is useful in delineating dynamic VISI patterns. The instability is produced by radial deviation and volar subluxation of a relaxed wrist. A visible and palpable reduction of the joint occurs with ulnar deviation. Although technically not a wrist joint, the distal radio-ulnar joint, DRUJ, is generally considered a part of the wrist joint because of its proximity. Working in concert with a proximal radio-ulnar joint, this joint provides for pronation and supination of the hand through its actions on the forearm. The main stabilizer of the distal radio-ulnar joint is the triangular fibrocartilage ligament, TFC. This is augmented by the dorsal and volar radio-ulnar ligaments within the joint capsule and attached to the TFC. Further support is provided by the distal interosseous membrane of the forearm. The TFC also provides support and articulation for the ulnar corpus. Injuries of the DRUJ usually involve the triangular fibrocartilage, the TFC. There are at least two classifications for TFC injuries, Palmer's being the more prominent. TFC injuries fall under two main categories, attritional and traumatic. Attritional injuries occur through repetitive compressive and shear forces between the distal ulnus and ulnar carpus. This is referred to as ulnar carpal impingement syndrome. Over time, thinning of the TFC occurs with fibrillation of the surface, occasional flap tears, and an eventual central perforation. Chondromalacia of the distal ulna and triquetrum usually precede TFC perforation. Ligamentous injury and instability at the lunotriquetral joint may occur. Arthritis of the ulnar carpal joint is an eventual possibility. Symptoms of pain often develop, but instability of the joint is rare. This syndrome is associated with ulnar positive variants, with the ulna lying more distal to the radial facet. Traumatic injuries to the TFC usually result from a fall on an outstretched hand or violent twisting injuries. Instability of the distal radio-ulnar joint, the DRUJ, is characteristic. Tears of the TFC may be central, the ulnar fossa, the radial insertion, the capsular insertion, or a combination of these. Tears are characteristically full thickness. Associated injury to the joint capsule, in particular the radio-ulnar ligaments, is to be expected with any instability. Traumatic TFC injuries are classified as pronation injuries. Supination injuries are combined based on the pattern of instability. and a pronation instability, the radius will exhibit increased volar translation relative to the ulna with stress testing. Radial tears of the TFC, when present, tend to be dorsal, and dorsal radio-ulnar ligament injury is more common. With supination instability, the radius will exhibit increased dorsal translation relative to the ulna with stress testing. Radial tears of the TFC, when present, tend to be volar, and volar radial-ulnar ligament injury is more common. Combined instability implies complete tears of the TFC and variable radial-ulnar ligament injury. Through the coordinated action of these three joints, the human hand has evolved an unmatched ability in the manipulation of our environment. If you have made it to this point, congratulations are in order. I hope you have found this presentation enlightening and entertaining. Thank you for your attention, and thank you for your time.